speaking on the mic is basically a hearing aid. Miniature form of this mic is what is the hearing aid what we put into our ear. That is just a kind of amplification device. A receiver and the amplifying the sound and reaching inside the ear. If we take a very basic anatomy of the ear, we have three parts, that is external ear, then middle ear, then internal ear. When we talk about cochlea, it is the inner ear what we are talking about. And again, in a very general terminology, if we say cochlear implantation, it is just a kind of bypass surgery. In hearing aid, there is no bypass. You hear, then tympanic membrane that amplifies the sound, tympanic membrane vibrate, same your bones, internal ear bones, then the cochlea, then the hearing cells, and the impulsation goes to the auditory nerve. Then you hear. But what I am speaking and what you are hearing, it is your brain which is reacting. And it is such a beauty of our brain even that when I speak, you hear in a second. And moreover, you even imagine. Say, if I say apple, you can form an image in your mind, apple. If I say aeroplane, you can find, it is just a fraction of second, not even a fraction of second, milliseconds. I speak and you form an image. Orange, apple, aeroplane. See how extempore you are forming the image in your mind. But see a person who is not able to hear because of some damage in the inner ear, in which the sensory hearing cells are damaged. What to do? This is where the technology had advanced. Moreover, tomorrow we will be fortunate enough that a few of the very eminent guests, out of which Padam Shri Dr. J.M. Hans, he is a cochlear implant specialist, Dr. A.K. Agarwal, he is Dean Director, Maulana Azad Medical College, then Dr. Achal Gulati, Dean Director, Dr. B.R. Ambedkar and G.V. Pant Hospital, they would be joining us tomorrow to share their experience. And moreover, we are having a series of research scholars and the faculty members who would be coming and sharing regarding their experience and their knowledge regarding the cochlear implant. Moreover, out of these, I was having a discussion with the heads of the department. They were saying that, sir, this type of conference, international conference, these days we are even also having 2 of the Skype recorded lectures from the international speakers. Sir, in this kind of conference, whether putting our students on the stage to present their paper would be fruitful, whether they are going to match that particular platform. I said yes, because this is the platform what I am preparing for my students. They are already learned people. But this is a platform what I am preparing for my students, so that the department students, the ASLP department, the HI department, if they come over here to present a paper, but obviously they have to do some homework. They have to prepare a paper. They have to get into depth into the knowledge of the particular subject. For getting the knowledge, they have to consult number of journals, number of research papers, more consultation from the teachers. So ultimately, they are going to put everything together and come up with a new research paper. And that is what we are looking forward, a research study at Ashtavakra. That is the reason that we gave this conference not the name of only an international conference on cochlear implant. No. This is our conference, that is ASHTACON, Ashtavakra Conference 2020. And this is a series what we are going to start this time, and I hope next time onward we'll keep it for at least 3 to 4 days, so that every student should get a chance to come over here and present their paper. Number of ASLP students come to my room and get that JC sign. I always ask them, what is the paper you are reading about? So that is the first step what they're going ahead. And moreover, see, as an Ashtavakra, we are now 1 decade old. We are almost 10 years into the field, out of which 5 years are for the BSLP program. And doing conferences, doing events, doing number of, you could say, the guest lectures, that is all not for us, this is for you, for having more exposure. So my interns, my ASLP department student, my HI student, MR students, take the knowledge. Reason, when a disability, when this kind of ailment come, it doesn't select. If a MR child will get in your field, it would not be only MR. When there's a damage, there could be a damage of auditory nerve even. So it could be MR, along with that there could be some hearing impairment problem. So you have to work as a team. with the references. Say X as an Ashtavakra student, now I am qualified, I am experienced, I am running a clinic in South Delhi. Say Y from a ASLP department. A Y other student who is qualified, experienced from MR department running his special education center in Rohini. Now he come across a student who is having a MR and challenge even in hearing. What he will do? I'll call my friend in South X who is a hearing specialized from the same department. You know who is a topper, who is doing best in academics. So this is a teamwork. Ultimately, when you go to a hospital under one roof, what you get? A dermatologist, a ENT, a physician, a gynec, everything under one roof. So this is Ashtavakra, in which we are forming a one roof. You must have seen our logo, a banyan tree, that having different roots. So do attend these kind of conferences. This is a pre-event what we are organizing only for you people. Today our purpose is only for student. I even told that everything should be hosted by the student today, because it would be a professional thing tomorrow and it will be taken care by all your faculty members. But take advantage of this stage, do participate, do present your papers, and do acknowledge them with certificates and even mementos so that they could be acknowledged that what they are doing. And I would be definitely attending your papers, initially what is scheduled in your particular minutes of the particular day. And I hope that you will make me feel good that you would be presenting something new, something related to research, what is happening. And I even wish that my faculty members also should start with number of research, what we are looking forward to develop a R&D department at Ashtavakra. Moreover, very soon we are going to start with some lectures even on research and development, so that you would be comfortable and convenient to do the research with the help of the software what are available in the market these days who conduct the research. And definitely we'll go organize some lectures even on that. But make sure that next conference what we organize should be on R&D, because that would be very helpful for the B.Ed student and for the ASLP student. So all the very best for this 5th International Conference. One thing more to add, on the occasion of World Hearing Day and the Cochlear Implant Day, I congratulate you all people because you are from the field. And also secondly, we are organizing an Ability Expo. That is an exhibition what we organize usually every year, but we haven't done since last 3 years. But this time again, we are organizing it for a day tomorrow. So do invite your parents so that they can attend the exhibition what we are having downstairs in the plaza. And thereafter you can attend the conference tomorrow. So tomorrow will be scheduled for the conference on 9 o'clock onwards. Make sure that you take your seats accordingly. And I wish you all the very best and all the entire team and fraternity for the success of this particular event. Thank you. Thanks a lot.
So before dealing anything, let's get started with our pre-conference ASHTACON 2020. Today's session will be chaired by Mrs. Jyoti and Ms. Tanvi, faculty and organizing committee members. Research always creates some new knowledge, and rehabilitation field individuals have always been curious and excited about doing research papers. So let us start with paper presentations. So for that, I would like to call Akansha Dagar to present her paper. The topic of her paper is Acoustic Features of Phonation and Perception of Voice Handicap in Chanters.
Good morning, everyone. I, Akansha Dagar of BSLP 3rd year of AIRSR, New Delhi, is going to present my research paper on the topic Acoustic Feature of Phonation and Perception of Voice Handicap in Chanters. Introduction. Chanters or Indian priests are professional voice users who use their voice while performing regular worship such as Hindu prayer, Aarti ceremony and fire rituals in temples and home. The recitation of Vedas and shlokas are taught to these individuals in the Gurukul system since childhood. Chanters are possibly classified under level 2 and level 3 in the category of professional voice users as given by Kaufman and Isaacson 1991. Due to the use of their voice in adverse condition, chanters may have vocal problem like vocal nodule, vocal polyp, vocal fold hemorrhage, vocal fold paralysis, etc. The ceremonies performed by chanters may last for hours in the presence of noise and smoke, which may lead to vocal problem. Moreover, chanters do not prefer to consume water during prayer recitation, which further puts them at the risk of voice problem. Any deviation in voice will have an impact on their profession, and voice damage in their professionals can be detrimental. Need of the study. The purpose of this research is to study the voice profile of chanter or Indian priests. Chanters have great vocal need than a normal individual. They speak continuously for hours, which may affect their voice and hence may affect their quality of life. Therefore, there is dearth to study voice handicap index in chanters to know the impact of their profession on their voice and quality of life. Aim of the study: to investigate acoustic features of phonation and perception of voice handicap in Indian priests. Methodology: Participants included in this research studies were 20, which exclusively included males. The age range was 15 to 48 years, and year of experience was 2 to 35 years. Exclusion criteria: individuals selected did not have any associated history of speech language disorder, cognitive disorders, reading difficulties, visual impairment, hearing loss, or swallowing difficulties. Inclusion criteria: individuals included had age range of 15 to 48 years and minimum age of experience was 2 years. Procedure: case history was performed, which included demographic data, medical history, year of experience, vocal hygiene. Voice handicap index consisted of 3 domains: functional domain, physical domain, emotional domain. Each domain consisted of 10 questions. Acoustic analysis included Saza ratio and maximum phonation time. Result and discussion: the mean value of the total score of voice handicap index of chanter or Indian priests and control differed significantly. Test of normality used was Shapiro-Wilk test, which revealed significant value for severity, and Saza ratio values, which were 0.000 and P significant value was less than 0.005 respectively. However, among physical, functional, and emotional domain subtotal score, a statistically significant difference was also seen between chanters and controls. Through the descriptive analysis, chanters' total score was higher than control. It was found that among chanters, physical domain was scored higher, followed by functional and emotional domain. It was found that when the severity of the voice difficulty was more, the physical and functional domain were rated higher by the chanters as compared to the control. Descriptive analysis: severity, mean was 1.66, median was 2, standard deviation was 0.485, range minimum was 1, and maximum was 2. Saza ratio, mean was 0.787, median 0.67, standard deviation 0.50, range minimum was 0.32 and maximum was 2.30. The analysis of voice handicap index score distribution showed that 67% of chanters estimated their own voice problem as moderate disability, while 33% of them reported as mild disability. Figure 2 showing the percentage of severity of voice handicap index. Severity and Saza ratio were correlated through Spearman's ratio rho correlation, and correlation coefficient was 0.820 and significant value was 0. Hence, it could be concluded that as the severity increases, the Saza ratio decreases. Conclusion: professional voice users are at increased risk of vocal cord lesions. The findings from the paper should enable the voice or speech pathologist or voice team to plan strategically to reach to prevent voice problem and maintain good vocal health. A voice specialist, while tailoring a program, should also consider the socio-economic, religious background of people involved so that the program becomes more centered to clients' need and reduces handicap of voice. Voice changes as related to age, voice overuse are of particular relevance of professional voice users. Understanding these areas of laryngology is important to the continuity of care provided to these patients by laryngologists. Vocal effect can be increased by practicing correct posture, breathing patterns, gentle warm-ups, and good rehearsal habits, and by using formal training. The vocalist must learn to mark and be wary of occult voice abuse. Great progress has been made towards understanding the function, care, and optimization of human voice. We now have the knowledge and vocabulary necessary for accurate analysis of voice problem and systematically logical solutions, and practical applications of these advances will raise the standard of voice care and training forever. These were the references. Thank you.
Thank you, Akansha. Before we move any further, we have Naila Ahmed from B.Ed HI department. She will be talking about cochlear implants, academic struggles, and educational modifications.
Myself Naila Ahmed, and I'm here to talk about cochlear implants, academic struggles, and educational modifications. So, first of all, I would like to start with a brief introduction of cochlear implants. Cochlear implants are sensory prosthetic devices that deliver electrical stimulation to the cochlear nerve in an effort to restore access to a wide range of acoustic input levels throughout the speech frequency range. Cochlear implantation is generally considered to be the standard of care for children and adults with severe to profound sensory neural hearing loss. And its implication for auditory verbal therapy has created opportunities for children with all degrees, types, and configuration of hearing loss to develop age-appropriate auditory skills and spoken language. And consequently, many of the children can be fully included in regular preschools and grow up enjoying the abundance of social and academic freedoms of life in 21st century. So, as we are talking about academic things, so let's know about the inclusion. Inclusion is a broader term referring to a complex process that involves the implementation of accommodations for adapting to each child's needs. And the intent of full inclusion is to ensure that children with hearing loss become full and active participants in regular classrooms, in general school environments, and in the larger societal system. And inclusion in school may require a teamwork, a collaborative teamwork from hearing research teacher, educational audiologists, speech-language pathologists, and other school personals. Though cochlear implant is a boon to children with hearing loss, still it has its own limitations. So let's see the academic struggles of cochlear implant recipients. So the first thing which comes is their lack of access to information. Though hearing technology provides them with adequate access, still there is lacking and lagging due to the presence of background noise, lack of background knowledge, and restricted incidental learning due to their lack of the skill of overhearing, which leads to listening effort and fatigue. Listening fatigue is the stress and fatigue as a result of the sustained speech processing and listening demands in a noisy environment like classroom, which jeopardizes their learning, compromising a child's academic performance. And it happens because of the auditory bombardment through the hearing technology, which they just can't avoid because it's constantly providing them the input. Difficulty identifying and discriminating the speech sounds because they are constantly in an endeavor to identify specific speech sounds, which increase the cognitive load. And there is a process called auditory cognitive closure, which typical hearing children can do. Like, for example, if they hear a sentence, I stir my coffee with spoon. So it's very natural that they'll understand that it's spoon. But with children with hearing loss, it becomes difficult for them to comprehend that it was not poon, it was spoon. So these are very small things, but for them it makes a major difference in language comprehension. Then sound identification. The inability to hear certain sounds can most certainly affect language comprehension, impacting on students' spelling, reading, and or phonemic awareness skill development. Not hearing the quieter and higher pitched sounds like s, sh, th, f, it can impact on their knowledge of plurals, possessive, and word-noun agreements, and subtle nuances of speech in sentences like the cat drinks versus the cats drink. So it actually changes the meaning of the whole sentence. Then listening in background noise. Listening in any amount of noise is extremely challenging for them, especially in a classroom environment. It leads to increased cognitive load, which impacts their following multi-step instructions, paying attention, and it may affect their note-taking. So the students with hearing loss who are even wearing the technology, they are always trying to keep up with their class, keep up with the teaching and the learning outcomes. Background knowledge and vocabulary are always, not always, but most of the time it's weak, which impacts students' ability to understand new concepts, challenging vocabulary, multiple meaning sentences, and idiomatic language. Like, for example, we say, it's raining cats and dogs, but they generally take the very literal meaning of cats and dogs. They won't understand that we are referring to a heavy rainfall. Then listening effort and fatigue is always a problematic thing with children with cochlear implants. Now we'll see the accommodations which are required for students with hearing loss, which can really help them out face these challenges. So, because of the immature auditory processing skills coupled with poor acoustics in the classroom, it becomes difficult for children to attend to the teacher's voice and to learn. But still, we have provisions, we have measures to make some accommodations to help them maximize their learning. Like, there are some basic classroom considerations which can be done to help most of the students. It's not specific to children with CI, but it will help them also. Like, keep the classroom door closed to minimize noise in the hallway from interfering with learning. Teacher avoids standing in front of a window so that his or her face can be seen without glare. All new directions, concepts, and information should be presented from front of the room. Adhere to a classroom routine. So even if a student misses something, they will be better able to predict what they should be doing or what will happen next. Maintain quiet during lecture times and classroom discussion when students will be expected to understand information. There are some teaching strategies for instruction, for giving the instructions. It should help and enhance child's learning by repeating or rephrasing the questions and or answers that peers provide, asking questions, asking students to repeat instructions, repeating or rephrasing classroom announcements, providing lyrics or explaining the lyrics of songs before the song is being played, ensuring that movies or videos are being captioned, and ensuring that teacher's voice is at a natural volume level. It should not be very loud or very soft. During classroom discussions, ask students to speak one at a time. Summarize key points made by students' answers or comments during class discussion. Write all assignments on the board, including textbook page numbers the class will be turning to in each lesson period. And if a visual is used, like a map, graph, or projected image, allow students a chance to look at the visual and describe what they are seeing so that they can perceive both auditory and visually, and they have the processing time to do that. Then there are some adaptations which we should do to make their listening better. Assign children to classrooms that have acceptable acoustics, like open plan schools are not advisable for children with CI. Noisy ventilation system, heating system, and cooling systems should be avoided. And furniture like tables and chairs should be provided with felt pads or tennis balls so that they are not making much of a noise or chaos in the classroom. Noise reduction should be there by the use of carpets. Specialized lighting should be there so that the face of teachers and peers are visible. And there can be some room design modifications like low ceiling, which will help the acoustics of the classroom. And then the most importantly, there are amplification options. First thing is that we need to make sure that the cochlear implants are functioning properly. There should be a listening check every day. And use of FM system is the most significant thing to listen in the classroom noisy environment, which helps increase the signal to noise ratio and makes hearing in noisy environment better. So signal to noise ratio is the relationship between the signal, speaker's voice, and the background noise. And use of FM system enhances it by around 10 to 15 degrees. An FM system can be attached with smart boards and videos and computers also. There are some communication accommodations. We can do specialized seating arrangements. Preferable is in the second row with better ear facing the teacher. Obtain students' attention prior to speaking. reduce auditory distractions, reduce visual distractions, enhance speech reading conditions, like avoid hands in front of face, mustaches well trimmed, no gum chewing, present information in simple, structured, and sequential manner, clearly enunciate speech, allow extra time for processing information, repeat or rephrase information when necessary, frequently check for understanding and comprehension by the child, and reduce the speaker to listener distance, which really is very important for better speech perception. There are some instructional accommodations like use of visual supplements, captioning, real-time speech-to-text translation, buddy system for notes, downtime or break time for listening to avoid listening fatigue, extra time to complete assignments, step-by-step directions, note-taking. And one more thing which is important is noise reduction, which is important to reduce the reverberation time, and it can be done by the use of carpets or rugs in the room. Like we need to make the hard surfaces soft. And then we have to expect the child to be an active learner, and the ultimate aim is that they should learn to repair the communication breakdowns. They can work with their teachers or their coaches, and there should be a mutual understanding between them so that they know where there is a breakdown and how to repair it. And students need to gradually learn to take responsibility for their own devices until they can check them independently every day and report any problems immediately. And students should remind teachers or adults to use FM devices and let them know when noise is interfering. So these are the self-advocacy skills which are required by any student or child with hearing loss to develop for an independent living. There are some curricular modifications like modify the reading assignments, written assignments, pre-teaching new vocabulary, provide supplemental materials, provide extra practice time, reduce the quantity of tests, use alternative tests, allow extra time. And then I would like to leave you all with some self-advocacy strategies which are like thumb of rule for any child, but especially the children with hearing loss or cochlear implants. It will help them live a life with self-affirmation and self-awareness and self-appraisal. Thank you so very much.
Next paper will be presented by Anisha, and the topic of her paper is Awareness of Contingency and Occurrence of Stroke in Advanced Age Group, a comparative study between males and females.
Good morning one and all. I Anisha Khanijo of BSLP 3rd year of Ashtavakra Institute of Rehabilitation Science and Research Center, presenting my topic on awareness of contingency and occurrence of stroke in advanced age group, a comparative study between males and females. Now I'll start with the definition of the stroke. Stroke is defined as an episode of acute neurological dysfunction presumed to be caused by ischemia or hemorrhage persisting greater than 24 hours or until death. Stroke is defined as a sudden global or focal neurological deficit resulting from spontaneous hemorrhage or infection of central nervous system with objective evidence of infarction, hemorrhage, irrespective of duration of clinical symptoms, which is given by American Stroke Association in 2009. Now I'll come to the epidemiology part. The incident rate in India is 119 to 145 per 1 lakh. The estimated prevalence rate in India is 84 to 262 per lakh in rural and in 334 to 424 per lakh in urban area, given by J Stroke 2013. Now I'll come to men are more likely to have a stroke than women, which the statement is given by CT in 2002. According to the recent medical study, across the world, there is 1 episode of stroke in patient every 6 minutes. Now, I'll come to the topic, the types of stroke. There are 2 types of stroke, that is ischemic and the hemorrhagic. Ischemic is defined as the clotting of the blood, and it further divided into subcategories: thrombotic stroke and embolic stroke. Now in hemorrhagic stroke, there is a bursting of a blood vessel. Again, it is categorized into two categories: subarachnoid and intracerebral. Need of the study: to check awareness among gender-specific population. Among all neurological disease, stroke is most preventable. However, due to the dearth of public awareness, there is a delay reported in admission to hospital, which directly affects the treatment and the recovery of an individual. The awareness of these symptoms and risk factors are essential for the public to effectively use therapy for acute stroke in a timely manner. Hence, this study was undertaken to assess public awareness of warning symptoms, risk factors of stroke. Now, my aim of the study is to present study aim to evaluate the general awareness of warning signs and symptoms as well as risk factors of stroke in general public. Now I'll come to the part of the methodology. In my 30 randomly individuals with the age range of 40 to 60. As I described in my title, it is an advanced age group study in which it is a comparison study. So we have taken 15 male and 15 female. We have used the questionnaire, valid questionnaire, which is given by Maiden et al. 2013, and we have also taken the permission from them. We have used the structural interview. We have excluded that are cognitive deficit or hearing impairment or language deficit. Now I'll come to the part, the result. The result from the section 1 revealed that 46.6 males had a highest educational qualification in bachelor degree, whereas for females it was 40%. Higher percentage of male and female participants identify the brain as the organ involved in stroke. Section 2. Stroke awareness revealed that only 6.6% of the female experienced a previous stroke, and a relatively high percentage, approximately 73.3% females knew someone who suffered from the stroke. As we can see, we can see from the bar graph clearly that among the participants, female reported higher knowledge about warning signs and symptoms, that is loss of speech, weakness on one side of the body, headache with neck stiffness, vertigo, and loss of eyesight. Now we come to the risk factor. The most commonly recognized risk factor reported by both participants of stroke were obesity, diabetes, and stress, whereas hypertension, smoking, and hypercholesterol were reported by males. We can see clearly by the bar graph. Now I'll come to the consequences. Among the consequences of the stroke, loss of ability to speech was reported higher by both the gender, whereas loss of ability to walk and one-side paralysis were rated by higher males, and loss of ability to hear was reported higher by females. About 85% of male population responded that they would contact the ambulance on sign and symptom appearance, whereas higher percentage of female population reported that they would contact the family doctor. Belief section result revealed that male gave higher rating on the questions related to the lifestyle alterations and the occurrence of stroke. Personal experience source was rated by both the participants higher, which provide knowledge of health and being healthy. Supermarkets were the places rated by both the participants higher to advertise information on the stroke awareness. Now I'll come to the discussion. In a study of gender-specific factors associated with knowledge of stroke warning signs, risk factors, women have higher knowledge about these factors, whereas men have higher knowledge about the consequences of the stroke. A familiar study of the gender-specific study was done by D. Giriot et al. In 2011, in which 45 articles were included, which represent total 67,000 patients, and here this study revealed that better stroke knowledge were observed in women than in men, although there is general lack of knowledge in both the genders. Our findings that women had better knowledge of stroke warning signs is similar to several prior studies. About 85% of women responded that they would contact the ambulance on signs and symptoms appearance, whereas higher percentage of male population reported that they would contact the family doctor. It is important to note, however, that despite more knowledge of stroke symptoms, women have not been found to reach the hospital sooner. In fact, some studies indicate that women have longer pre-hospital delays. In a hospital-based study performed by Bindu Menon in 2014, assessed awareness of the public regarding stroke in 350 subjects were interviewed, which revealed that there is a poor knowledge of recognition of stroke, its warning signs, risk factor, and pre-hospital care. Now we come to the conclusion, the last part. The impact of the knowledge of stroke symptoms, consequences, and risk factor are seen more in females. Most of the females showed high prevalence of the knowledge of the stroke. However, despite of being aware about stroke contingency, there is a delay in hospitalization because they neglect the alarming signs and symptoms of stroke. Among both the genders, the most common risk factor are the diabetes, obesity, getting older, and the stress, whereas the most common consequences are loss of ability to speech and one-side paralysis. Belief section results reveal that male gave higher rating on the questions related to the lifestyle alterations and the occurrence of stroke. Personal experience source was rated higher by both the participants, which provide knowledge on health and being healthy. Supermarkets places was rated higher by both the participants to advertise information on the stroke awareness. Thank you.
Thank you, Ms. Anisha. Our chief guest of the day is Ms. Ira Singhal. She is Deputy Commissioner, North India Municipal Corporation. But she could not be here with us today, so she has sent a video.
I wish all the best to the conference that is being held on the World Hearing Day and International Day of Cochlear Implants. I hope the message that you're trying to spread goes far and wide, and it really makes a difference to all those lives who really need this help. So congratulations to the whole team, and best of luck, and I give all my good wishes. मैं सिर्फ ये कहना चाहती हूँ, अगर डिसेबिलिटी पे फोकस करोगे तो दुनिया सिर्फ डिसेबिलिटी देखेगी. तुम्हारे अंदर बहुत सारी एबिलिटीज़ हैं, सिर्फ सोचने की बात है, सिर्फ उन्हें पहचानने की बात है. तो सिर्फ अगर आप अपनी डिसेबिलिटी पे फोकस करोगे तो दुनिया भी वही देखती रहेगी, क्योंकि जो हम दुनिया को दिखाते हैं दुनिया वही देखती है. आप अपनी एबिलिटी दिखाओगे तो दुनिया एबिलिटी देखेगी. शायद शुरू में 1-2 दिन, 1-2 महीने, 1-2 साल लोग ना माने, बट अगर आप अपनी एबिलिटी पे ही फोकस करते रहोगे, अपनी एबिलिटी को ही उभारते रहोगे, तो दुनिया वो देखने पे मजबूर होगी, दुनिया वो देखेगी. एंड मैं ही नहीं, मैं बहुत सारे ऐसे लोगों को जानती हूँ जो अपनी एबिलिटी के बेस पे आज बहुत कुछ कर रहे हैं, चाहे कुछ भी डिसेबिलिटी हो, चाहे कुछ भी उनकी प्रॉब्लम्स रही हो. प्रॉब्लम हर किसी की लाइफ में आती है. उस प्रॉब्लम को आप किस तरह से लेते हैं, किस तरह से देखते हैं और उसे अपनी ज़िंदगी पे कितना हावी होने देते हैं, ये डिसाइड करेगा कि आप कहाँ तक जा रहे हैं. So this is to all of you kids out there. Please think positive about yourself. अपने लिए पॉजिटिव सोचो, तभी दुनिया सोचेगी. अपनी एबिलिटीज़ को ध्यान में रखो, अपनी एबिलिटीज़ पे फोकस करो, एंड दैट इज़ द ओनली वे समवन इज़ गोइंग टू गिव यू इम्पोर्टेंस. दैट इज़ द ओनली वे द वर्ल्ड विल सी योर एबिलिटीज़. डिसेबिलिटीज़ सबके लिए है, किसी की दिखती है, किसी की नहीं दिखती है, किसी की फाइनेंशियल है, किसी की इमोशनल है, किसी की मेंटल है, किसी की फिजिकल है. तो क्या फ़र्क पड़ता है? आपकी एबिलिटीज़ भी तो कुछ है. तो लेट्स फोकस ऑन दैट, एंड गुड लक टू एवरी वन ऑफ यू हु इज़ हियर अटेंडिंग द कॉन्फ्रेंस, एंड आई होप यू ऑल गो ऑन टू डू ग्रेट थिंग्स.
Now I would like to call Kunika Rana to present her paper, and the topic is Vocal Concerns Across Elderly Teaching Professionals working across government and private organizations, a comparative survey analysis in Delhi.
Good morning, everyone present here. I am Kunika Rana, BSLP third year. I am here to present my paper, that is Vocal Concerns Across Elderly Teaching Professionals Working Across Government and Private Organization, a Comparative Survey Analysis in Delhi. Introduction. Voice plays an important role in lives of many professionals as their financial and social lives depend on voice usage. Teachers have great amount of vocal demands in their professional life and are part of professional group. Those frequently present vocal problems with impact on quality of life. Elderly teachers' voice problems are described as tired, weak, or effortful voice and physical discomfort while speaking, given by Smith, Lemke, Taylor, Kircher, Hoffman, 1998. There is a paucity of research in an Indian setup on the voice concerns in elderly population in private and government organization and provide information to elderly teachers about voice issues arise in old age and brief knowledge about vocal hygiene and vocal rest. Need of study. The excessive and long-term use of voice, environmental factors, workload, gender effect increases the chances to develop voice-related complaints in elderly college teachers, hence lead to an impact on emotional aspects and secede from work with social and financial emanations. Teachers use their voice with varying environmental conditions, hence glottal attack can harm their vocal folds. Therefore, study focuses on providing information to teachers to make them aware about age effect as well as about vocal hygiene and vocal rest. Aim of the study aimed to profile voice-related concerns in elderly teachers by congregating aging factor, gender effect, health status, emotional impact, and communication-related quality of life in different organizations. Methodology. 40 elderly college teachers were included in the study, mean age range between 40 to 60 years. Group A consists of government organization that has 20 participants, 10 females and 10 males. Group B consists of private organization that has 20 participants, 10 females and 10 males. Demographic detail and medical history were taken through a structured interview. Material. Questionnaire for elderly college teachers that was taken from Aishwarya Nalmuthu and Prakash Bhuminathan, 2011, was used to assess the voice concern in elderly college teachers. The questionnaire consists of 25 questions which assess 5 domains: general health, knowledge and awareness of developmental changes, factors affecting voices in elderly, voice characteristics, its effect on communication in daily situations. Result. In section first, lifestyle and general health, smoking, 40% males in government organization reported that they have habit of smoking and 80% males from private organization. And percentage of females were high in government organization. Alcohol consumption, 90% males from private organization. Non-vegetarian diet, percentage higher in both organization, both gender from both organization. Water intake, percentage of male and female is higher in private organization. Second, general health, difficulty in hearing. 30% females reported have difficulty in hearing from government organization and 50% males from private organization. Difficulty in swallowing, male and female show higher percentage from government organization. Gastric problems, male and female from private organization show higher percentage. Problems related to menopause, females show higher percentage from private organization. Knowledge about voice change due to aging, females show higher percentage in government organization, whereas males show higher percentage in private organization. Present voice characteristics, effortful speaking, both gender of both organizations show higher percentage. Voice sound rough, male show higher percentage from government organization, whereas female show higher percentage from private organization. Emotional impact, voice change, upset or annoy. Male and female show higher percentage from private organization. Communication in daily situation, male show higher percentage in government organization and female show higher percentage in private organization. Discussion and conclusion. The result from present study revealed that smoking habit is high in private organization rather than government organization. As smokers are at risk of developing swelling of vocal folds, smoking causes deleterious effect on mucosa of the larynx that can lead to decreased vibratory efficiency of the vocal folds. Schwartz et al. 2005. The percentage of consumption of non-vegetarian food was comparatively higher in both gender in both organization. NGTY 2000 stated that increased intake of non-vegetarian spicy food can lead to heartburn, in turn causing laryngopharyngeal reflux. Alcohol consumption is high in private organization. Alcohol can lead to swollen and inflammation of vocal folds and usually result in low-pitched voice. Landsman SM 2018. It was reported that male and female of private organization showed higher percentage of adequate and frequent intake of water, at least 2 liters per day, to avoid vocal fatigue. Problem during menopause is seen more in private organization as estrogen level affects vocal fold elasticity and flexibility. During menopause, vocal fold dries and lead to dryness of throat. Davis 2004. Emotional impacts seen more in private organization as their voice can affect their job performance and efficiency. Costa et al. 2013 reported that vocal performance decreases due to emotional factors. Elderly teachers are those professionals that are more vulnerable to develop voice-related issue because of their work schedule as well as due to increasing age. Hence, it is recommended to provide knowledge to elderly teachers as due to lack of awareness of these risks may ultimately increase elderly teachers vulnerable to voice disorders. It is important to improve knowledge to make them aware to protect their voice and to stay healthy vocally through vocal hygiene program. These were my references. Thank you.
So that was all from the paper presentation side.